next one, case number 2 for Córdoba. Put the slides, please. Case number 2 for Córdoba. So, next one. Perfect.
Well, this is our second case, and it is about a 54-year married mother of 3 healthy child, and she works as a school cook, and she suffered from easy fatigue and moderate dyspnea on exertion. Her weight is 66 kilograms and her blood pressure is 126 over 75 millimeters of mercury, and her peripheral saturation is 97. She has a mild 2/6 systolic ejection murmur at the left upper sternal border with a fixed splitting of the second heart sound with a mildly increased pulmonary component. About her past medical history, he only has 3 sections without complication and a cholecystectomy in April 2014. She is on hydrochlorothiazide, 25 milligrams each day.
Next one.
And pertinent test, the EKG is in sinus rhythm with a heart rate of 85 per minute and with an incomplete right bundle branch block. And she also has a crotachas sign, which is a notch near to the apex of the right wave in inferior limb leads. And the chest X-ray shows cardiomegaly and dilated MPA and a bilateral pulmonary plethora with increased pulmonary vascular markings. The TE echo shows a multiple ostium secundum type ASDs. The largest defect is measuring approximately 20-21, and a smaller defect measuring about 10 millimeters with 4 up to 6 millimeters separation from each other. Right atrium, right ventricle are enlarged, and there is a mild to moderate elevated PA pressure.
Next one.
This is the chest X-ray.
Next one.
And then the EKG with the sign in the inferior limb leads.
Next one.
And next one, there is a 2D TE showing the defects. And on the left, the largest and the smaller one, and the flux
next one.
Through it. And this is a 3D TE with the measure the 2 different defects. And Next, please. And this is the cardiac catheterization with the multiple ASDs balloon sizing. And we can easily see the two defects, the smaller the upper left and down the bigger. And our intended intervention today for this case is a percutaneous ASD closure using the PFM nitroclude ASDR device.
Okay, next. So we just moved forward and did all the hemodynamic for this patient. The SV sat is 73, the PA sat is 88. There is a QPQS of 2.64 to 1, and the PVR is 4.81. You see the PA pressure, the mean is 29, so it's mild pulmonary hypertension, and the RPRS is 0.16 to 1. So all these numbers mean that it has a mild pulmonary hypertension, 54-year-old, and with a large QPQS and dilated right side chambers. So next one, stop. So let's see now some echo pictures. Alejandro will show for us some echo pictures. And there's some new findings here. There is a large ASD that is measuring approximately between 17 and 21 millimeters. There is a rim of tissue there that is approximately 3 to 4 millimeters. And also there are a couple of, we saw with just one more ASD, but here with the wire we cross a tiny extra or multiple ASD also during this cardiac catheterization. You see there just one by one, Ale. just to show the 2D and then 3D, so they can have an appreciation regarding the size of the ASD. Next one, and the location. So the question that first I would like to ask is, when you have 2D and 3D measurements, do you think that the 3D measurement, that is a reconstructed image, you trust those measurements or you go from just with balloon in this case, or with 2D measurements? Can you just mention that for me?
Does anyone have any answer to that question? The 3D measurements versus balloon sizing? Anybody? Go ahead.
Yeah, I'd always balloon size these rather than just going by the 3D measurements for sure.
We would as well. 3D measurements sometimes are very difficult to figure out in our hands, at least in my eye. And I always just use the balloon size with both balloons inflated.
Yeah, it gives you a nice sort of, perspective on where the holes are and how they relate to one another, but we'd rather measure by balloon sizing or 2D echo.
Okay.
Anybody have any thoughts about that? Anyone with more experience with echo? All right. Why don't you just go ahead? There's no comments here.
Yeah, perfect. We have the same impression that we trust the 2D and also the balloon sizing. So, Angel, now we just crossed both ASDs and we measure with balloon both. This is the larger defect, and I try to be very gentle with the inflation. And the next one. This is the smaller defect that is located inferiorly with the larger one. You see there. Next one, you see the measurement. That is a little bit with more pressure to see how close we were from the second defect down there. Next one, and see the measurements of the larger one. The smaller one is 5 to 6 millimeters, and the larger one with a stretch with really good wood inflation is between 20, 21. So this is there is a discussion here to see how will you approach this patient. Both two ASDs, one is smaller than the other, and there is a discussion if you think that both needs to be closed, one first and the second in a later stage, or how is the approach that you would rather to do for this patient?
Okay, we have a couple of questions and comments from the audience. Go ahead.
Yeah, in this kind of patients, I do always balloon sizing at the larger hole. During this time, put a color Doppler and then measure between the other defect sizes. If it is not much more than the color diameter, of course, not more than 7 to 8 millimeters, because we don't know how they will be closed during the balloon sizing. So after that, I decide to use one device or two devices.
Zia?
This is a complex, obviously, ASDs, two large ASDs with not much of a tissue rim between the two of them. So if this case I'm doing now, what I will do, I will choose a large device. So your stretch diameter for the larger device is 21. So probably I will go with anywhere from 5, 26 to 28 millimeter device and leave it alone, knowing that you will have residual shunt. Come back after maybe 3 to 6 months and then cross and then use a second device to close the residual defect. But doing two devices here is going to be complex because there is not much of rim for the two devices to hold on.
Can you tell us once again, what was the balloon size of the smaller hole?
Between 6 and 7 millimeters now.
I'm not sure I would do it the same way Z said. Go ahead, let's go ask around the audience.
Well, honestly, I don't find it's a very complex ASD. The rim between the two is very small. What I do myself is measuring the total defect, outer edge of one ASD to outer edge of one ASD, and this is my size of device, and they almost never have residual shunt. Would measure the, by your very nice 3D echoes, the outer to outer diameter of the two ASDs, and that would be it. It's oversizing, but...
Well, just to be controversial here, I probably would close this with two devices. I would put the smaller device in first, and I put the larger device in second. They would hold each other in place, and I don't think it's a terribly complicated thing to do here. It's probably what I would do for this type of device. But I think there are a lot of different ways of treating this device. This holds. Go ahead.
May I share a little bit idea? Because the concern would be that strand is strong enough or just soft one. So what I don't know, what I will do in this patient, I will try to squeeze that strand with the balloon, whether it's kind of stretchable or not. If it's not stretchable, so it's not worth to do the bigger, size of the device. But if it's stretchable, then definitely we'll go for the bigger size.
Macro.
Another point, assuming that this is a straight plane and they are the same plane, most of the time when they put the two devices, you're going to find that they're at an angle for each other. So I think I would do what Bill just suggested. I usually put the first smaller device, don't release it, and put the other one, and then release them. And most of the time, they're not going to be the same plane at all.
I agree with that. I wouldn't release either one until they were both in place to put it in there. So let's go ahead quickly, but please go ahead and tell us what you're going to do. We only have about 20 minutes left, so why don't we go ahead? Go ahead. One more comment.
Just a comment on using two devices, because sometimes when you use the larger device only, it tends to prolapse the left disc into the smaller device. Because again, like Makram said, they're not on the same plane. And I had this happen, and then you're stuck. You can't put another smaller device in the small hole, and the device is really just falling into the smaller hole. Just a comment.
Good, Jack.
Alejandro needs to continue anyway, but the point I was going to make was earlier on, there was a comment from him about cost becoming an issue. And if cost is an issue for PDAs, then cost is a bigger issue for ASDs. And so he's probably better off trying one big device than trying to squeeze the other defect.
All right, let's go ahead. Let's move ahead with the case, see what you're going to do.
Perfect. So what we think to do here is how we approach multiple ASDs here, because there is a very, very nice experience. You see that this is very infrequent to publish multiple devices for ASD. So we actually, our strategy is we follow Horst Sieber and Nina Wunderlich's paper from CCI 2013, where they published a large experience with multiple ASDs, 148 patients. They had the stage approach or the conservative approach. They close the larger defect first, and then after 6 months, a year, they reevaluate the patient and then see if necessary a second device. And very interesting is that the complete closure during the first implantation was 26%, and at 2 years, it increased to 74%. So meaning that even closer defects with the fibrosis and with the endothelialization can potentially close or make those holes smaller, that they don't need to be treated. That the summary, and also I like to emphasize that if you have a stage approach for this type of cases, you will use fewer devices in this patient, and if you have to put a second device, there is data saying that your second device during a stage approach is smaller, so the risk of tamponade, erosion, and atrial arrhythmia is a little bit less. So I think that we will keep with that, with our decision to try to close the larger defects and see what happens in the future with the smaller defects. Are you okay with that?
All right. So which one device? What size are you going to use?
Okay. So this this balloon sizing has been between 21 and 21.2. Siad said the largest device you can get there. I think that for our purpose, I think that at 24 device, we have a sheath, PFM sheath that is 14 French. So from this sheath, we can implant the 24, the 26, 28. PFM ASDR device come from 8 to 30, so the largest is 30. With that waist, can you show the audience the angio with that waist in the balloon, please? Next one. Next one, the measurement. The measurement, that one. With that one, that you have that my pressure on the balloon has been has not been the very very gentle, meaning is 21. You think that the 24 is okay for this here that you comment the size of the device?
Yeah, I think that would be fine to do it. I mean, we close that hole, and it probably. I see no problem with that selection.
Okay.
Anyone have any thoughts about it's not an appropriate size? Well, see, I was to go to a 28 to try and close both holes with one device, but I have no problem with you closing this hole with a 24. I mean, it's your operator choice at this point. If you're going to use this device, it's a relatively softer device that I think you can go up to. I think it's really your choice what your goal is here. If you think you can use the larger one as a better chance of closing it long term with a single device, that's a choice you can make. We have a comment here in the audience.
Alejandro, could you do me a favor? While you balloon sizing on that, if you can do echo, whether is there any residual shunt, significantly on the small hole or not? Because my concern is that strand is quite stretchable or not. So if you can do me a favor.
Yeah, actually we have crossed with the sheath already, but Alejandro Contreras, our echocardiographer, has some images when we balloon inflate with the balloon sizing. Can you show Ale balloon sizing picture, please? So next one. Next one. Next one. Next one. This is the smaller one. Next one. This is the smaller one. Next one. The larger one. Okay. So that's the larger one. Are you okay with that?
So it looks as if that is stretchable, right? Because now you can't see the small hole.
Yeah, that measures 21 there. The balloon sizing was exactly what we got in angio, 21.
Right, so 24 should be fine then, to close both defects.
Okay. Okay, so we have ready here the 24 ASDR device from PFM. We use this device very frequently. I just, in the previous case that we closed the fenestration, I just went through all the details of the device, the locking wire, both disc, the membrane you see there, double disc, and here how it is released from the right atrial disc with the snare there, the snare. So you retrieve the locking wire and the snare freezes the device. This has a special adapter here. This comes for the PFM sheath that has a special adapter, so the transition is very nice now. So this comes as a unit, as you see here. Everything is pre-mounted. So we just need to move forward and just to load the device and go through the. So now we put this in saline, and you see there how the device is properly loaded into the loader. So with Adolfo and Johnny here, we will just flush this properly. Air is our enemy here, so
What size sheath is that across the hole?
this is a 14 French sheath, Bill, but the 24 device is just in the middle between 13 and 14. So just for the purpose of if we have to upsize the device, we start with the 14 French sheath. It's 14 French PFM sheath. It's a special sheath that comes with the device now. It's a braided sheath. So we are ready. We are ready here for advancing the device. You see the sheath, the tip of the sheath that is radio opaque is just at the tip of the left pulmonary vein there. We'll see how this strategy works or no. So the device is nicely making the transition and going into the tip of the sheath there. You see it, and you see the locking wire that goes into the left pulmonary vein. You have to be very aware of that does not bend on something, because if that bends, you cannot release the device later. So it's very important to confirm the position of the locking wire, the distal locking wire. So now, Ale, we will start releasing the device into the left atrium, coming down a little bit, and you see there how the device will be open. There. So you have the reverse reconfiguration of the device. You see the Chinese hat type of reconfiguration. As you see the wings of the device, and the locking wire goes up to the pulmonary vein, so we are okay with that. I think we are not going to have problem to release the device. Now just check the echo. Checking the echo, we're coming down, and you see how the device is approaching the ASD. You see there? So Ale, are you happy with that?
Yeah, we can see it all. Go ahead.
There, Ale? Okay. So that is the Chinese hat, and we'll see if that is okay to open the right atrial disc now and see what it reconfirms, because it's an ASD that is tricky. There, Ale, it's okay. It's better. Looks small according to our echocardiographer. So we'll try to open the right atrial disc now. I think that is okay there. I actually think that this is a good position of the device there. Echo bigger, please. It was not difficult to open the device in that position. You see there how it grabs. So right in the middle, you don't see nitinol. It's just a membrane. This is why it goes up and down. And you see also the locking wire. And it's very important with our experience. It's very important there to see that the membrane is not very flat. If the membrane is very flat, means that the device is just right. If it has some waves like you see there, means that the device is good size for the defect that you are trying to occlude. Do you understand that?
I think so. Go ahead.
And there's also, Ali, there's also probably a limit with this device on how much you can oversize it.
Sorry, can you repeat the question, please, or the comment?
Yeah, there's a lot of talk about oversizing this device, and different devices do different things when you oversize them. This is a very different device design, and if you oversize it too much, it does distort some of the discs. How much do you think you could have oversized this?
Oh, yeah. Very, very, very good question. This is a device that you cannot oversize a lot because due to its reconfiguration, the right atrial disc is the device is grossly oversized, does not reconform, does not adopt the concave shape. It's like a pine shape. So it's difficult to make this device to reconfigure like this if it's grossly oversized. I think that this is one of the devices that you have to keep just in 1, 2, up to 3 millimeters the balloon stretch diameter. This is my impression. I don't know if somebody else in the audience has large experience with ASDR device can comment about that.
Go ahead. Question?
I think this is an important question about the erosion because even though there are not huge numbers of used as ASDR in ASD closure, 2 erosion have been reported. One from my center, it was not oversized, but the right atrial disc equal to left atrial disc. We have observed the origin at the right atrial roof. So during the oversizing, because of the structure of the ASDR, it is very close than the afflator-like devices, and a little bit may cause more tension on the aorta and also atrial roof. So about the oversizing should be considered carefully.
I think it's an important point about if that's true that's happened with this device. Any other comments about that? Are you gonna you see any other hole there at all? Any flow through any other hole?
Yeah, Ali, can we see color on the echo?
Yeah, color, Ale. Color with la ganancia. It's common to see color when you because, as I explained before, the membrane in the left side has always some color passing through and going through the device. Here, I don't know if you see some big. Ali, can you just scan the septum so they can get a better appreciation of the Okay, so just color there. Color. It's hard to tell you if that blue color is coming through the device like always does from the left side and going through the device, so it's an additional hole. We think that here we chose an conservative approach just to close the larger hole and see what happens in the future. I think that for this 54-year-old lady is enough to close that large hole and see what happens in the future. Maybe in the next PICS I will let you know if we had to implant a second device or not. Everyone is happy if we go and release the device?
I think so. Go ahead.
Okay. So, Bill, you do the Minnesota wiggle or not?
I have no experience with this device. I have never done it, so the wiggle, so I usually wouldn't even bother. Anybody else here would try? No, I don't think anybody here would do that.
No? Okay, let's keep with that. So, now that we are happy with the position of the device, just my hands will free the locking wire, and here you have the security seal that we just moved. And
can we see your hand?
My hands, please.
Can we see your hand also?
My hands. So here we just move the security seal here, and you see the locking wire. So we just start, Angel now, we just start bringing down the locking wire, and the locking wire is coming down, 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 so it frees the device nicely. You see that the device didn't move at all. This is another advantage of this device. When you put the device in the septum, it's not gonna make any funny movement after you release. You see the platinum markers that were there, you release the device, and still there. So, Ale, last pictures, I think that the device is in situ and has a good position there. So we have just one more minute. Any other question or comment?
Can you show us the echo big screen, please?
Big echo. Okay, so it's 2D, color, 3D now. 3D. Okay. Okay. So, Bill, still with this outcome and with what you see here, you will still stick to your original comment to put 2 devices?
Well, I only have I don't have this device to work with. So given the devices I have to work with, I would not want to oversize the big hole. So if I was going to do this and I thought there were 2 separate holes that had some distance, I would still use a small device in one hole and use maybe an 18 or a 20 in a large hole and hold it in place, because I don't want to oversize. If I have access to all the other devices, I might change my approach to doing this. I think what you showed clearly that this is probably the right way to do it, and there's very little residual leak at this point in time, and I congratulate you with what you did.
Nice result.
Okay, thank you.
All right, thank you very much. Have a good day. Thank you for all your contributions. Listen, a couple of more announcements before I end this session.